Hello, and welcome to the US versus HPV webinar series, which has taken place from January the 22nd through January the 28th. I am Viamonte Ros and the moderator for today's talks. This webinar is hosted by the American Medical Women's Association, Global Initiative Against HPV and Cervical Cancer, and Indiana University, to recognize January as Cervical Cancer Awareness Month. In addition, this webinar is also being hosted to spread awareness about the various diseases caused by the human papillomavirus, or HPV, beyond cervical cancer, and the excellent and effective tools that we have to prevent them. Our goal of this webinar series is to raise knowledge and to encourage and empower you, the audience, to join us in this campaign. You have a number of ways to access this event: live stream, dial-in, and video replay. All webinars are recorded and are free. You have a number also of ways to get information about this series at Us versus HPV on the GIAHC homepage, or by Googling Us versus HPV. You can also find us at Facebook, Instagram, and our Twitter handle is #Us versus HPV. A big thank you to our coalition sponsors. Today's topic heading is cervical cancer, past, present, and future. And we will have 3 speakers for this session. We will then open the floor for questions and answers. You can submit your questions at any time starting now through the Q&A icon that you will find at the bottom of your screen. Selected questions will be answered live during this session. I will be the first speaker today, and I am an Associate Dean for Women in Medicine and Science at the Herbert Wertheim College of Medicine, Florida International University, and Medical Director of Palliative Care and Bioethics Services at Baptist Health, South Florida. My talk is going to be on cervical cancer, a preventable public health problem, and I have no disclosures. What if I told you that I knew for a fact that 10 747 airliners full of passengers were about to crash into the ocean sometime this year? I don't know when it's going to happen. I don't know who's going to be on the plane, but I know it's going to happen. What would you do with this information? Well, if it were me, I would do everything I could to find out where and when these crashes were going to happen, and then warn everyone that I could not to get on those flights, and I'm sure you would do something very similar. Well, right now in the United States, the equivalent of 10 airliners full of passengers is crashing every year. Passengers who are dying from cervical cancer. And these deaths are almost entirely preventable with a simple vaccine. And we need your help to get the right people vaccinated and screened in time to save these people from dying. A death from cervical cancer is really like a slow preventable plane crash. If you look at how it happens, it involves about 3 steps, each of which we can tackle. First of all, HPV can be transmitted both non-sexually and sexually, with sexual transmission being absolutely the most common mode. HPV is a very common and widespread virus. Nearly everyone will be infected in their lifetime. And in most cases, HPV infections go away on their own and do not cause any health problems. But sometimes it doesn't go away. And when this happens, cancer cells can start forming. When the cancer cells are allowed to keep forming and growing, we get a cancer, which grows until it starts to affect your health. Somewhere along the way, you might start to experience symptoms. And I just want to mention here that HPV causes a number of cancers besides cervical cancer in both men and women. HPV can also cause cancers of the mouth, throat, anus, penis, and vagina. In both men and women, HPV also causes genital warts, although these are different strains of HPV than those that cause cancer. The special thing about cervical cancer is that we can actually prevent each stage of this process. When people get cancer, we can sometimes prevent death by removing it with surgery or killing it with chemotherapy and radiation. Before the cancer develops, we can find and remove precancer changes through screening. That's where we have Pap tests. And before we even get infected, we can vaccinate. The CDC recommends HPV vaccine for boys and girls at ages 11 to 12 to provide protection long before they are exposed to the virus. Boys and girls who start the series before their 15th birthday need 2 doses. Those who start the series on or after their 15th birthday need 3 doses. If you have a teen who did not start or finish the HPV vaccine series when they were younger, talk to their doctor or nurse about getting it for them as soon as possible. Girls and women are recommended to get HPV vaccine through age 26 and boys and men through age 21. And remember how I mentioned that usually the infection goes away on its own, but sometimes it stays around? Well, 2 major factors that allow an infection to stick around and become cancer are also preventable. One is if you smoke, you should stop smoking. Something about the toxins from cigarettes weakens your immune system and makes it harder for your body to get rid of the virus. The other risk factor is no screening. And we find most people who get cervical cancer have not had a Pap test in the last 3, 5, or even 10 years. So getting screening is extremely important. Just to say that of all the ways to prevent cervical cancer, vaccination is really the best approach over the long term. We have a great and safe vaccine, and we are certain that almost all cervical cancer is caused by the HPV virus. Just a few lines about the vaccine. It's available for boys and girls, and it can be given anytime between the ages of 9 and 45. But it is most effective when given before teens start having sex, when the immune system is the strongest and the exposure of the virus is the least. But people can benefit from the vaccine even if it's given later. The vaccine is generally given in 2 parts for teens or 3 parts for adults. This slide gives you an overview of the state of cervical cancer in the United States. These are some very big numbers. In 2018, the American Cancer Society estimates that there were 13,240 new cases of invasive cervical cancer in the United States. And like I mentioned before, about 4,000 women died. Pap screening rates are high right now, but they are not 100%. We don't have exact numbers, but it looks like about 7 of 10 women are up to date with their Pap tests. And HPV vaccination rates, although they are growing every year, are still relatively low. Only about half of the kids receive the recommended doses of the vaccine. We do see a difference in vaccination between girls and boys, with girls more likely to be vaccinated. But despite all the great benefits of the HPV vaccine, and even though it's been around for 13 years, vaccination rates are still lower than for other age-appropriate vaccines. Here are 3 vaccines that we recommend for all teens around age 11 and 12. There's a combination vaccine, tetanus, diphtheria, and pertussis. The light blue vaccine protects against meningitis. And the yellow is the HPV vaccine. And you can see rates are still much lower for getting HPV, even though all 3 should be given at the same time. And we can also see that different groups are getting cervical cancer at different rates. Black and Hispanic women are more likely to get cervical cancer, and when they do, they are more likely to die. It is a cancer of poverty and can affect anyone who has less knowledge and access and affordability to get vaccinated and get screened. This includes whether it's whites from Appalachia or Blacks and even Hispanics. For example, Black American women die from cervical cancer at rates comparable to many developing countries. And part of this is due to cultural reasons. A lot of it is due to access to care. People in rural areas, rural white teens included, are also less likely to have gotten the HPV vaccine. The number of teens who received the first dose of the HPV vaccine is 11 percentage points lower in rural areas than in urban areas. And there are a lot of factors in play into these differences. And where people aren't getting vaccinated, we also see higher rates of cervical cancer. For example, the rate of cervical cancer in Texas is double that in Washington state. This is a cancer of poverty. The key thing about HPV is that it's everyone's issue. Whites, minorities, men, women. While men don't get any symptoms when they're infected, they can surely pass HPV on to women. And there are pretty big differences in vaccination rates. Boys, as I mentioned, are much less likely to get vaccinated than girls. The LGBTQ community is also at higher risk. First, there is a 44% higher rate of smoking within the LGBTQ community, a risk factor, as I mentioned, which makes it more likely that HPV will lead to cervical cancer. So it's equally or more important to get screened. I mentioned that HPV can cause a number of other cancers, including cancer of the throat and anus. These cancers are found in men, especially among men who have sex with men. So it's also very important that men who do have sex with men get screened for HPV-related cancers. There are usually a lot of reasons, small and large, that add up to someone not getting vaccinated, and we can work to address all of them. I will touch on a few. There's the option of a school mandate. These definitely work, and in fact, in Australia, if you don't get the HPV vaccine, you cannot go to classes, and as a result, Australia has over 90% of their kids vaccinated, and as a result, HPV-related genital warts have all but disappeared. But school mandates are politically hard to sell, and they are controversial. Some people feel it puts up barriers to kids going to their classes. So most US states do not have a mandate. At the moment, in fact, only 3 of 50 states have included a school mandate, and most of these mandates are only for girls, even though both boys and girls are supposed to get the vaccine. Health professional attitudes towards the HPV vaccine can also make a huge difference. If your doctor feels the HPV vaccine can be an uncomfortable conversation, and a third of them do, you're much less likely to get vaccinated. But we know doctor and nurse recommendations can lead to a big difference in vaccination rates. Finally, sometimes kids and parents have unanswered questions about the vaccine. They don't know if it's safe. Well, it is. Or if it will lead to problems like kids having sex earlier. It does not. Unless the myths out there about HPV and vaccines in general are addressed, there will still be a few cases where people hold out because of unnecessary fears. While there are some real barriers to getting vaccinated, cost is actually not one of them. Most people can get coverage for the vaccine through their commercial insurance, such as through your employer or through your parent's employer if you're under 26. If you're 18 or under, you can get the vaccine for free through the Vaccines for Children program, and Medicaid covers it further till age 20 and higher in some states. Merck also has a patient assistance program which covers the HPV vaccine for people who have special financial and medical hardship and meet the program's income criteria. And what can healthcare professionals do to increase vaccine rates? Well, first, they need to get really comfortable with the conversation. We know that recommendations from your doctor or nurse work. For example, 13% of LGBTQ people in one study were vaccinated. However, that number rose to 83% when their doctor or nurse recommended the vaccine. A good way to get comfortable to offer HPV on the same day is and in the same way as other vaccines. So please consider that. Other effective approaches include standing orders that allow nurses and other healthcare professionals to give the vaccine even if the physician isn't there, and using automated messages to remind patients to return for their next vaccine dose. I just talked a lot about vaccination. If we can get 100% of people vaccinated, we can eventually wipe out cervical cancer. But until then, and for the older generation who didn't get the vaccine, we still need to do cervical cancer screening, which here you can see in the orange box. And right now it's important to note that even though those who have been vaccinated, they still need to be screened, because even though the vaccine is very effective, it is not 100%, as almost any other vaccine. They're not 100%. Vaccination and screening, however, with early treatment is 100% prevention. If you're a woman between the ages of 26 and 65 years young, you should have a Pap test within the last 3 years. The Pap is a great thing, and about 7 of every 10 women in the United States are up to date with their Paps. That's a good thing, but not good enough. As with vaccination, we know that access and coverage can be issues. While the Pap is great, it's not that comfortable. It takes a visit to the doctor's office. You have to undress. It's not something you do for fun. But we know that Pap tests can save lives, and most women who get cervical cancer have not had a Pap test within the last 10 years. To improve access, some places are letting women self-collect their Paps to make the test a little more comfortable. In the United States, the National Breast and Cervical Cancer Early Detection Program offers free Paps to people from low-income populations and may well be available in your area. So what should you do? Well, if you're a woman between 21 and 65, make sure you get your Pap smear. You should also talk to your friends and family about HPV and cervical cancer. If you're between the ages of 9 and 45, talk to your healthcare provider about the vaccine. And if you have teens, talk to them and their healthcare provider about the vaccine. And finally, advocate for change by writing to your political representatives to encourage them to pass legislation to protect Americans from HPV. And even though today's focus is on cervical cancer from a public health standpoint, all should get vaccinated to prevent as many HPV diseases and different types of cancers, as it can affect everyone, men, women, and the LGBTQ community. We have an opportunity to almost wipe out a disease with a vaccine, so you too can prevent plane crashes. It starts with talking about it. Thank you so much. Our next speaker is Dr. Nancy Church. She is a board-certified obstetrician and gynecologist who specializes in minimally invasive surgery. She is very active in the American Medical Association and the American Medical Women's Association. The title of her talk is Pap Smears and Beyond, Newer Screening Modalities for Cervical Cancer. Welcome, Nancy.
Thank you, Anna. Disclosures. I have some relevant financial relationships. I'm a private OB/GYN practitioner. My practice is called Wellness Connections, LLC. I do occasionally receive payment for occasional speaking engagements on gynecologic surgery topics. My non-financial relationships, I'm a member of the American Medical Association. I'm an elected member and secretary of the the governing council of the Organized Medical Staff section at the AMA. And I'm also the American Medical Women's Association representative to the AMA House of Delegates. There's been an evolution of cervical cancer screening since cervical cancer first started with the Pap smear in the 1940s. Cervical cancer is the fourth most common cancer in women worldwide. It disproportionately affects women in low-resource countries that lack a public health infrastructure to support cancer screening. The slow rate of progression from precursor lesions to invasive cancer provides opportunities for early detection and cure, as Anna Viamonte so nicely described. Cervical cancer incidence in the United States has definitely declined substantially over the past half-century. What is unique about the U.S. mortality attributable to this neoplasm is that the vast majority of deaths will occur among our poor women, women from communities of color, non-U.S. born women, and women living in rural and remote settings. Routine screening of cervical cytology with the Pap Pap smear has been deeply ingrained in clinical practice for those of us who practice gynecology for the past century. Annual cervical cytology screening has been a standard of gynecological care for the well woman exam since the 1960s. When the Pap smear was first developed, it actually reduced the rate of cervical cancer. This says 50%, but actually reduced it by 70% with the original very simple Pap smear, which is purely a screening test for the cells sloughed off the cervix. Harold von Hausen, MD, identified viral causes of human cancer. Originally, the Pap smear was highly associated with the herpes virus. And then was evolved through Harold von Hausen, MD, to be identified with human papillomavirus types 16 and 18. He and his colleagues proved that two HPV proteins, E6 and E7, interfere with the function of cell cycle proteins, resulting in a deregulated cell growth, leading to cancer. A lot of cancers are involving deregulated cell growth. These discoveries led to the development of both HPV vaccines and tests to identify high-risk HPV in cells and in tissue samples. So cells are your Pap smear, the cells that sloughed off the cervix. The tissue samples are the colposcope, which follows up a very abnormal Pap smear. Primary cervical cancer screening by cytology is still an option. That's your Pap smear. But HPV testing has greater sensitivity. Therefore, cervical cancer prevention is now closely tied to the prevention of human papillomavirus transmission and the recognition of patients who are infected with the HPV and who are therefore at higher risk for developing cervical cancer. Data suggest that more than half of cervical cancer cases could be prevented through adequate screening. 50% of women diagnosed with cervical cancer have never undergone cervical cytology testing, and another 10% have not received screening in the 5 years preceding their diagnosis. Furthermore, cervical cancer is very rare among screened women, less than 10 per 100,000 annually. Current guidelines for cervical carcinoma screening were created in 2012 as a joint recommendation of the American Cancer Society and the American Society for Colposcopy and Cervical Pathology. These recommendations were then accepted and promoted by the American Congress of Obstetricians and Gynecologists later the same year. A recent HPV FOCAL randomized clinical trial done in July of 2018 asked the question, does cervical cancer screening using primary cervical HPV testing compared with cytology result in a lower likelihood of cervical intraepithelial neoplasm grade 3 or worse, CIN3 plus or CIS, at 48 months? The conclusion and relevance. Among women undergoing cervical cancer screening, the use of primary HPV testing compared with cytology, that's our Pap smear testing, resulted in a significantly lower likelihood of CIN3 and more at 48 months. Some frequently asked questions. Why did we change from 18 to 21 years for a Pap? So in this country, it's now 21 years. In some countries, it's anywhere from 20 to 24 years. A number of the studies found that in young women, they're likely to slough off the human papillomavirus, and that a lot of invasive procedures that could be harmful to the patient were done when these young women would, because of their young, good immune system, might be able to slough off the virus. Another question. Why is the HPV test only recommended after age 26 or 30? We know that women under age 30 have a very good immune system, for all of us to be in our 20s, where they can slough off that virus. Over age 30, it is far less likely for a woman to slough off the virus that she has contracted. Why is Pap still a good test? It's still a good test because it can still act as a screening test. It brings the woman into her gynecologist or her family physician. She's still getting a pelvic exam, a breast exam. Her perineum is looked at. So all in all, it is still a part. It's a simple part of your annual screening to protect yourself. If one gets the Pap HPV DNA test, do they need the HPV vaccine? Absolutely. So as Anna Viamonte so nicely said, the prior Gardasil was Gardasil 7. Actually, it was a Gardasil 4 before, but Gardasil 7, which protects against 7 of the most high-risk human papillomaviruses. The newer Gardasil, Gardasil 9, prevents against 9 of the high-risk viruses. There are about 200 different DNA subtypes of human papillomavirus, of which 20 are some of the high-risk types. The HPV 16 and 18 are the worst, coming under the category of E6, E7. And these still are protecting you. So even if you're getting a Pap smear, you can certainly contract the virus. Why try to treat after the fact instead of preventing before the fact? If one gets the HPV vaccine, do they still need screening? As I kind of hinted at in the prior question, there are still enough viruses out there that are not covered by the Gardasil. Some of our information on the Gardasil virus vaccine is that if you got 2 of the Gardasil 7 but never got your 3rd, what should you do? You certainly can go and get the 3rd of the Gardasil 9 and it will cover you. So just because you had 1 or 2 and then had a laxity of follow-up does not mean that you should not continue. Thank you very much.
Thank you, Nancy, for a wonderful presentation. Our final speaker today is Dr. Sarah Feldman, Director of Ambulatory Gynecologic Oncology at Brigham and Women's Hospital and Associate Professor at Harvard Medical School. The title of her talk is Can We Eliminate Cervical Cancer? The Role of Cervical Cancer Screening in Preventing Cancer. Welcome, Sarah.
It is my pleasure to speak with you today. Thank you so much, and to follow 2 excellent talks. So my question is, can we eliminate cervical cancer? And we're going to talk about screening updates. I have no conflicts of interest to report. So let's talk first about the objectives of cervical cancer screening. As previously alluded to in the 2 prior talks, we want to prevent cervical cancer by detecting high-grade dysplasia. That's another word for a precancer, and treating those high-grade dysplasias before they can progress to cancer. If for some reason we are unable to find the precancers before they progress to cancer, we still want to find the cancers very, very early, because those are still very curable cancers. But at the same time, we want to balance the intervention related to the screening process with over-screening or over-testing, especially in young women, because sometimes that over-testing is not beneficial for preventing cancer and may actually cause reproductive harm. So right now, the American Society of Colposcopy and Cervical Pathology is working on creating better, what they call risk-based testing, which is going to help us balance detection of precancers with avoiding overtreatment or overmanagement of lesions that will resolve spontaneously. So let's talk about what is known about cervical cancer screening and prevention. This is a very dense slide, but it's good because you can keep it and remember all these things. So almost all cervical cancer is due to infection over time, so persistent infection with one of the high-risk human papillomavirus subtypes. There are actually 12 to 14 HPV types that have ever been associated with cancer, but 2 of them, HPV 16 and 18, are the most concerning and most aggressive. Up to 80% of people, however, will get one of these 12 to 14 subtypes at some point in their lives, both men and women. And it is only those patients that have a persistent high-risk virus infection that become at risk for developing cervical cancer. Once infected, most patients will clear the virus. Now, I need to make that clear to you that when you clear the virus still exists in the body. You will test negative at that point, but it can be reactivated at times of stress or low immune system, low immunity, or at other times. So once infected, you have the virus. You are potentially contagious, but since most people have it, most people are contagious, but you are only really at risk for developing one of the cancers if you test persistently positive. The way you test positive is by one of the human papillomavirus tests. Currently, those tests are administered by your clinician at the time of a pelvic exam. The Pap and HPV can be tested together. They can be tested separately. The HPV can also be tested alone with some of the tests. If your HPV test is positive for several years, usually at least 2, you're considered a high-risk patient. Patients who are at increased risk of developing cervical cancer, either because they've had an abnormal Pap or because they've had persistent HPV positivity, are at risk of developing high-grade dysplasia, which is also known as moderate or severe dysplasia, or some people may refer to it as CIN, CIN 2 or 3. Of note, mild dysplasia, low-grade dysplasia, or CIN 1, those are all three names for warts. Those are not precancer. So if you have one of those, that is not considered a precancer. We can prevent cervical cancer by detecting these precancers, but we're only effective at preventing cancer if we also treat the patient before they develop the cancer. And of course, I can't emphasize enough, as my two prior colleagues have said, that the most effective prevention is still going to be childhood vaccination against human papillomavirus. So let's talk a bit about the natural history of CIN or dysplasia. As I mentioned above, low-grade dysplasia is not considered a precancer. Some people will call it mild dysplasia, some people will call it CIN1, some people will call it condyloma, some people will call it warts. 60% of those lesions will resolve within 1 year without treatment. And 90% will resolve within 3 years. So we don't treat low-grade dysplasia, and we don't consider it a precancer. Now, I have to also clarify one point here. When you get a Pap and it shows a mild dysplasia or low-grade, that is not what we're talking about here. The Pap is a screening test, and then you go for colposcopy and biopsy. About 15% of people who have a low-grade Pap abnormality will have a high-grade precancer on biopsy. So when we're talking about the ability to resolve spontaneously, we are referring to the biopsy. It's very confusing that they're called by the same terminology. So these are now biopsies. When you have an abnormal Pap, low-grade or high-grade, we don't yet know what your biopsy is going to show until you have the biopsy. So the high-grade dysplasia lesions are considered precancerous, and those include the CIN 2 or the moderate dysplasia. And some percentage of those will also regress within a year, which is unusual for precancers, but is true in this one. And CIN 3, which is known also as severe dysplasia or carcinoma in situ, has the highest risk of developing invasive cancer within 30 years. Now, one thing that's upsetting to people is even patients with treated CIN 3 can sometimes develop cancer, and that's why those patients remain at very high risk and need very frequent surveillance even after treatment. Also, although there's a 30% risk of developing invasive cancer over 30 years, what's disturbing to people is that sometimes people will develop it in 1 year, and other people in 10 years, and other people in much longer. On average, it's about 10 years. But it's not exactly predictable, which is one of the frustrating things. So HPV infections in young women, how long do they last? So in younger women, ages 16 to 23, they studied the incidence of human papillomavirus 6 and 11, which are the ones that cause warts. Those are not precancerous HPV types. And 16 and 18 that are the most virulent cancer-causing HPV types. I don't know why my screen is moving, so I apologize. And anyways, on average, the HPV type 6 and 11, which would cause warts, will clear on their own within about 8 months. And the average duration of 16 and 18, which are the most virulent types, is twice as long. So we think that that partially explains why they're more likely to develop cancer, because they hang around longer. HPV-related cancers in women. So the very top line is cervix, that's the blue line. The red line is vulva, and across the bottom you can see patient's age. Important also is oropharynx, which is turquoise, and anus, which is purple. One thing you can see about cervical cancer is that it peaks at around ages 30 to 39. And even though it comes down, you can see that it doesn't come down even into the 80s. So although current guidelines have stated to stop screening at 65 for people who've had normal screens, we continue to see a substantial number of cervical cancers into the 80s. So for people who are otherwise healthy and have a long life expectancy, continuing screening after that point is reasonable. Vulvar cancer is the main cancer that does continue to go up, HPV-related cancer that continues to go up in that age group. So what are our current screening options for a healthy asymptomatic woman with all normal prior results? Let's just start by saying, why did I emphasize in red healthy asymptomatic? So healthy, if you are immunosuppressed, the guidelines are different. So you have to be completely healthy. Asymptomatic, if you have bleeding or some other sort of symptoms such as bleeding after sex, pelvic pain, a bizarre discharge that there's no explanation, you are not asymptomatic. These screening guidelines do not are not appropriate for you. And if you've had a history of treatment for abnormal results or evaluation for abnormal results, or have ever had an abnormal result, you do not go to these guidelines. These are only screening for people who are healthy, asymptomatic, and all normal prior results. So women ages 21 to 30 will start with just a Pap alone every 3 years. At ages 30 to 65, we change to 3 options. Continuing with Pap alone every 3 years, if all results are normal, is appropriate. According to the U.S. Preventive Services Task Force, it is possible to start at that point with HPV alone every 5 years. More on that later, though. We'll talk more about that. And then what's pretty standard in the United States right now is a combination of Pap and HPV co-testing every 5 years if all results are normal. If any result is abnormal, then you get evaluated and you're going to be followed more closely. So what are the pros and cons of screening? As Nancy mentioned earlier, the standard of care was annual Pap screening, and that reduced cervical cancer screening by 70%. And so it was very effective. It did prevent cervical cancer. But we do know that most of the HPV infections that people have and some mild to moderate precancers are going to resolve spontaneously. And if we screen people too frequently, we can pick up too many of these precancers that actually would resolve spontaneously. And the problem is that when we treat, we usually treat with an excisional procedure called a loop or sometimes a cone, or sometimes we burn the cervix or freeze the cervix, but most of the time it's with an excisional procedure. Multiple of those can impact a woman's ability to have a full-term delivery, so a normal pregnancy. So we don't want to do too much over-treating. So that's what we're trying to balance here. So in terms of Dr. Papanicolaou, he, as we heard many times, he developed a test where a superficial layer of cervical cells are removed with a brush or spatula, and they're sent to a lab. The sensitivity or the pickup of even the most severe lesions is only 50 to 70%. So the value of the Pap test was that, you know, if you repeated it many, many times, you were unlikely to miss something, and that's why the annual time frame was very good. But it does miss about half the abnormals, and so it's not a perfect test. This shows you the number of people who are diagnosed with, or the percent of people who are diagnosed with cervical cancer who had a previously normal Pap within 3 years, and that's 28%. That's more than a quarter of the patients who were diagnosed with cervical cancer previously had a normal Pap in the recent past. Half of them were not screened at all, so we know that that's a big issue. So lack of access, lack of education, resources, whatever, but that's a big issue. And then a few of them are that had abnormal results and no follow-up. So what are our options? So the Pap and the HPV together is called co-testing. That means that every single patient gets 2 tests, the Pap and the HPV test. And as I mentioned before, this is one of the acceptable options for women 30 and over. It is very sensitive, meaning that because you're doing 2 tests, it does not miss the cancers or precancers. But it actually may be too sensitive and result in many, many more colposcopies or treatments for women who don't really need them. So that's a very significant difference, because the number of colposcopies can go up by many magnitudes. And colposcopies, for any of you who've had them, or for those of us who perform them, are unpleasant for patients. We really don't want to do extra ones that are not necessary. So more recently, the idea of just doing the HPV test alone, called primary HPV testing, has come forward, certainly with U.S. Preventive Services Task Force guidelines. So this is going to test just for the presence of one of the 12 to 14 high-risk HPV types. The problem is it's only FDA approved for 2 tests, and those tests are not available yet in most settings. It is very sensitive, means it won't miss most cancers or precancers, but it may result in more colposcopies and treatments who may not actually need them. This approach is new. We don't yet have really good guidelines about how to manage the results, how frequently to see people. So it's not quite, I would say, ready for prime time, but it's probably very promising for the future. This is showing you how the negative HPV test or the negative co-test can really be most helpful, and that is by providing reassurance. So in the blue line, you see the Pap test, and that would be if you had a normal Pap test within the period of time across the bottom. The red dash line is if you had a normal or negative HPV test along the period along the bottom. And the green line is the cytology or Pap plus the HPV test negative. And it shows you that the greatest reassurance, for the incidence of high-grade dysplasia or worse is obviously by the combined testing of Pap and HPV. And here along the bottom, you can see number of months, and you can see 12 months at 1 year. There's still the Pap is not as reassuring as the other 2 tests, but then the other 2 tests are even pretty good out to 16 months or 5 years, showing the incidence of CIN3, also known as carcinoma in situ or cancer, per 10,000 women is at about 20. At the same point in time, you can see that a Pap alone is way up there with about 80 carcinoma in situ or cancer per 10,000 women. So significant difference in reassurance from those 2 tests. So after you have an abnormal screening test, the effectiveness of the screen is dependent on subsequent management. So first of all, on subsequent appropriate diagnosis and treatment. And for more information on what the current management recommendations for abnormal results, you can visit the www.asccp.org. And I mentioned earlier, but I will say again, that they're currently at the present time developing new management guidelines, which will hopefully be somewhat risk-based, so help each patient understand her risk, and will also probably be available in about 6 to 9 months. So those guidelines are based on the concept that current management guidelines treat all women the same way. But we now have a lot of information that shows that your past history predicts your future risks. So if you have a history of an abnormal Pap or HPV, you already are jumped up into a higher risk category than somebody who's had all normal results. This is showing you the risk of CIN3 or greater, so in other words, carcinoma in situ or cancer at 5 years as in relationship to your prior history. So if you have had 3 negative co-tests all the way on the left, you can see that your risk of developing CIN3 or worse at 5 years is almost 0. And that's also even true with 1 negative co-test. And it's true for women who have been HPV vaccinated. But if you have an HPV positive test but have previously been HPV negative, your risk is going to go up to 4 per 10, actually it's 4 per 100,000. If you're HPV positive and we don't know your risk, I mean, in other words, we don't know what your Pap showed or whatever, then that's actually a mediumly high risk group, and that's going to go up to up 7 or so. And then treated cancer or treated adenocarcinoma in situ or treated CIN3, your risk is even higher. So these prior risk information are extremely important. So in summary, we should be able to prevent cervical cancer. We know what causes it, human papillomavirus. We know that vaccinating all people under the age of 26 with the nonavalent vaccine, so the nonavalent vaccine, just to remind you again, protects against 7 of the highest risk subtypes and the 2 for warts, and that will likely decrease the incidence of HPV-related cancers and have the biggest impact. It's actually assumed that if every young person were to get that vaccine before the onset of sexual activity, that we could prevent about 90 to 93% of cancers. However, it's also important to reassure ourselves and our children that most people with HPV will not develop cancer, but if you're known to have tested positive, still get followed closely. It is the persistent HPV infections, especially with 16-18, that dramatically increase the risk of cervical cancer. Part of what we want patients to do, as well as our colleagues, professionals to do, is to make sure you know what the patient's past screening history was, because it helps you to understand what the risk is now. Thank you.
Thank you, Sarah, so much. Magnificent presentations from both Dr. Church and Dr. Feldman. Thank you so very, very much. We have some minutes now for question and answers, and we've have some great questions that have come up. So let me start. When a patient clears the virus and they are in an inactive state, can they still transmit the virus? Who would like to take that?
I would be happy to. This is Sarah. So the answer is yes. So it turns out that people are contagious pretty much all the time. So that anytime you have a new partner, you have to presume that you're at risk of getting HPV from that partner and they from you. So unfortunately, the inactive state does not dictate if you're contagious, which is very different from some other viruses like herpes.
Great, thank you so much. We had a question about public health and some of the barriers, the greatest barriers in order to accept vaccination and to adhere to vaccination. And again, I would say primarily it would be education. And it's education not only of the patients and their families, but also of the providers, and understanding and getting them comfortable and having these discussions early on. And of the public of demystifying some of the issues, that it does not encourage early sexual activity. Some of the complications people might liken to having other types of vaccines. So again, it's really education. Affordability, I touched upon that. There are many, many ways in which the vaccines are covered, whether by your employer, if you're under 26, under your parents' insurance, but also there are also patient assistance programs. So affordability should not be an issue. But truly, it's access to care and education on the part of the patients, the families, as well as the providers. We have a number of questions also about the vaccines that are really, really interesting. One of them is there just seems to be a sort of a moving target as to the different ages. Why is it different for girls and for boys? Why is that? And also, if you are within the group of 3 vaccine series and received 2 vaccines, forgot about it, never came back, years later, can you come back for the 3rd vaccine? So if someone would like to tackle about the vaccines and the difference in ages between girls and boys, and also if you did not complete the series of the 3 vaccines when they should have been given, can you still make that up later on?
I'll take that, Anna. This is Nancy.
Thank you, Nancy.
So what is on the horizon, just to take a few steps forward before I go backwards to the question, is the future holds the fact that our children will be vaccinated at the young age of 2 to 4, when most children are vaccinated in the future, because that's when their immune system is strong enough to really respond well to develop immunity. But right now, of course, we are at the ages of 9 to 12. Boys it was not recognized that boys should get vaccinated for quite a while, mainly because I'm not quite sure why they didn't see the relationship between boys and girls being sexually active. But then when they began to discover that boys had such a high risk of head and neck cancer from the HPV, it then began to be promoted for boys to also get the vaccine. At this point, I think it's related to puberty and the immune response as to the differences in ages. The question as to whether if you stopped a while ago, can you go ahead or do you need to start over again? If you got the Gardasil 7 a while ago and you got 1 or 2, you can go on and get the Gardasil 9 to finish the series, and it will protect you as well. You do not need to start over again. I think I answered most of those questions, Anna.
You did. Nancy, just a follow-up. Why not vaccinate very young children?
They do not yet have the approval, and I think there's some, they don't have enough testing yet to see what the effect is, but that would be the wiser thing to do when we are used to vaccinating the children between age, 18 months and 3 or 4 years. It would be much wiser to do it then, because that's when everyone is used to getting those vaccinations. So public health-wise, it would be much smarter. That's still in the works.
Okay, thank you. And what if someone is truly not sexually active? Do they still need a Pap test? Sarah?
So yes, unfortunately, they need a Pap for several reasons. The first is reported sexual activity is not always accurate. Remember, this is skin-to-skin contact. It can be skin-to-skin contact with a male partner, a female partner, any partner. It could have been years ago. And so even if they're not reporting having vaginal sex, they may still have been exposed. We also know that there's sometimes people have been traumatized and had sexual abuse that they don't disclose. So we sort of have set the 21 as the age when the rates of cancer start to go up. So we don't want to miss anyone. In addition, there are rarely non-HPV related cancers that can be, visualized, and you want to make sure that the patient has a normal gynecologic anatomy. So there are many reasons, but the biggest reason is that we unfortunately do see cancers in women who don't necessarily report standard sexual activity.
All right. And what about lesbians in your practice? Do they need Pap smears? I would assume it's the same.
So there have been many studies that show that women who have sex with women are equally at high risk and need to have the same exact care as women who report sex with with men. I also think one of the points that I like to make is some of these questions are a little bit generational, like we're older, but a lot of the young people are much more gender fluid and have sex with different sorts of people at different times. And it's not as clear, it's not as binary definition of have they ever had sex with men, women, or both. It's sort of, it's fluid. So you want to make sure that they're protected.
And what if a woman comes to you who's had a previous hysterectomy? Do they still need to be screened for HPV?
And I'd like to go back, this is Nancy, I'd like to go back
please.
For a quick moment. There's also, it's not just skin to skin, but there are also reports in the literature of digital genital HPV transmission, where people are developing cancer of the squamous cell nail bed from having had contact with HPV positive partners. So we don't want to forget some of that transmission as well.
Absolutely. Thank you so much. Thank you for elucidating that. And what about someone who's had a previous hysterectomy? Should they be tested for HPV?
This is Nancy. I'll take that again. Again, we said it's skin to skin.
Yes.
And we've seen some, I've seen quite a few vulvar cancers, HPV related. See it a little more with smokers, but certainly the HPV can spread to the vagina. It can spread to the vulvar area. So just because the cervix is gone doesn't mean you're not vulnerable to insult.
I just wanted to say that the actual recommendation is that for women who've had a hysterectomy and have never had an abnormal Pap, cervical dysplasia, or abnormal HPV, the current recommendation is actually to stop screening. I sort of agree with Nancy that I'm concerned, but definitely if they've had a history of any sort of dysplasia of the cervix, vagina, vulva, any of those areas, abnormal Paps, positive HPV, those women continue on screening for the same period as everybody else.
Excellent. And Nancy, in your practice, when you tell someone, a patient, that they screen positive for HPV, how do you recommend to them to tell their partner?
Very carefully. You have to, as a as a physician treating women, I know a lot of my women very well. I know what their relationships are, but I first sit down and talk with them about how serious it is for them. Then I ask them what their relationship is with their partner so that I can lay the groundwork for how it should be approached. Herpes still scares my patients and they're in tears without the seriousness of the human papillomavirus. So I tread very carefully there. But I do say they need to have an honest discussion with their partners. I tell them it often takes at least 3 years for human papillomavirus to even evidence itself after interaction with someone else, a partner who's positive. So we have a long discussion about that and where to go from there.
So I have to beg to differ. I actually have a very different approach. My attitude is 80% of people test positive. We don't routinely test men. Therefore, 80% of men test positive and don't know about it. What I say to the patient is if it's important to your own relationship to your partner in terms of your own health, then you share it with them. Like if you have to have a procedure to your cervix and it may affect your childbearing, of course you do. But other than that, it's your choice. There are many viruses, such as the common cold, we don't share with everybody we meet or expose people to. HPV is really common, and I don't like burdening the woman with the concept that she's at fault or that she's infecting another person. Most of the time, she's acquired it from an asymptomatic partner who doesn't know they have it. So I don't like the sort of self-labeling that goes about with disclosing this. It's quite different from gonorrhea, chlamydia, syphilis, HIV, or herpes, all of which have a negative consequence to the partners, and you want to make sure they're treated. But in this case, there's no treatment, there's no prevention. It's sort of up to the patient in terms of what, in my opinion, whether or not it will help them personally.
Thank you. There are a couple more questions, again, vaccine related and age related. Again, if you have never had sexual intercourse and even the digital form in any way, if you're truly a virgin above the age of 26, if you are an older woman, let's say, beyond the age that's recommended for the vaccination, and have systematically tested negative with your Pap smears and HPV testing, can you benefit in any way from the vaccine, even if you're beyond the age that's suggested?
Yes, you can, absolutely. It's absolutely reasonable on an individual basis to consider the vaccine in that sort of situation. That being said, on balance, from a public health perspective, vaccinating people above 26 is probably not going to be particularly effective, partially because of what Nancy alluded to before, is that the immune system is way, way, way more active in younger people. Adolescents and children are the best people to receive the vaccine. By the age of 26, your immune system is sort of elderly, believe it or not. So you won't respond similarly, but I don't think there's any harm, and you may be in a situation where there is some benefit.
Nancy, anything you wanted to add to that?
No, I think, Sarah does more public health than I do, and I think she very nicely summed that up.
Excellent, excellent. I wanted to finish up this session with asking both of you some good resources for our listening audience to tap into if they wanted to get more information, what you all would recommend to your own patients.
So I refer patients to the website of the American College of Obstetricians and Gynecologists, and I tell them that's at least honest and good information compared to a lot of the myth that's on the internet.
Thank you. And Sarah, anything else you'd like to add?
Yes, I totally agree with Nancy. I think ACOG is probably your best resource. CDC also has nice information. And we also have a website called Prevent HPV Cancer, which is just for patients. And you can go on there and get some quick questions answered. It's all based on CDC documents, but it's sort of more fun, especially for the adolescent, to learn more about vaccination, et cetera.
Excellent. Thank you so much. Well, that brings us to the end of today's webinar. Please, again, visit us at Us versus HPV for details on accessing the recordings of the webinar. Our other colleagues will be here at the same time on Monday, January 28th, which will be the final day of the webinar series, and the topic then will be on HPV and cervical cancer champions. Thank you to my colleagues, Dr. Feldman and Dr. Church, for fabulous presentations. And thank you all very much for joining us and your participation and your excellent questions. We look forward to you joining us in our HPV awareness campaign. Thank you so much and have a wonderful rest of the day. Thank you.